Pleased to welcome Dr. Katie Chaput. But before we begin, I would like to acknowledge that we are on Turtle Island. This is Treaty 1 land and territory of Dakota, Anishinaabe, Inninewak, Athinawak, Anishinninewak, and Dene peoples, and the homeland of the Métis Nation. We acknowledge our water is sourced from Shoal Lake 40 First Nations. We acknowledge the past harms, ongoing injustice, and pain of the present. We are committed to expanding our knowledge related to the rights and responsibilities of the people in this area. So just a few housekeeping items as well. This session will be recorded and available on the SCY website shortly after the session for those of you that couldn't attend this morning. As this session is recorded, you might want to keep your cameras turned off and muted. And then we will finish recording before the question period. So if you would like to unmute and ask the question yourself, that would be welcomed. Or if you prefer, enter it into the chat box, and I'd be happy to moderate that session and relay those questions at the end. So today we are welcoming Dr. Katie Chaput from Calgary. The topic today is perinatal depression, facts, figures, and current research. Dr. Chaput is a perinatal epidemiologist and assistant professor in the Department of Obstetrics and Gynecology and Community Health Sciences at the University of Calgary's Cummings School of Medicine. Her overall research interests lie in perinatal health and center on the optimization of perinatal treatment and services to improve maternal mental health, substance use, and associated infant-child health outcomes. The perinatal period can be a difficult time and a period of vulnerability for both the mother and the infant. And Dr. Chaput studies this period as a valuable opportunity to positively impact the health outcomes of both mothers and children throughout the life course. Dr. Chaput uses advanced methods of inquiry and analysis to address health research questions that are pertinent to impacting the health of mothers and children who have previously proven difficult to properly analyze, contributing to conflicting and controversial results. Her aim is to improve maternal and infant health outcomes in Canada through research. So welcome very much. Welcome, Dr. Chaput, and thank you very much for joining us this morning. I will now turn the presentation over to you.
Great, thank you very much, Dominique. Just gonna get screen share. Well, let's get started. So again, thank you very much for that lovely introduction. I won't go over my own stats again because you've just heard them all. In addition to the beautiful acknowledgement that Dominique just made, I would like to do an acknowledgement as well today, given that I'm here speaking to you from Calgary. I think it's important to acknowledge that I am on traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. The city of Calgary is also home to the Alberta Métis Nation, Region 3. I also think that given that I'm here today to talk about the mental health and distress of mothers and parents, I feel it would be a real dishonor to all families affected by the atrocities committed against Indigenous Canadians under the residential school system not to acknowledge the discovery of the 215 children at the Kamloops residential school recently. I pledge and encourage others also to take an active role in reconciliation in my work within health. And one of the ways that I do this is to find the calls to action that apply to me through my personal and work life, through the Reconciliation Commission of Canada report, and that can be found at trc.ca if you're interested in doing the same. So on to the presentation today. Today I'll be going over a few different things. I'll start off with sort of an overview of perinatal depression, what it is and who and what it impacts in Canada. I'll talk a little bit sort of woven throughout that portion about some of the recent successes and ongoing challenges in clinical and public health related to perinatal depression, specifically in the Canadian context. And then I'll go over a couple of ongoing research projects that I currently have running and talk about how those have been designed to address some of these challenges that we have. I'd also like to make a note on the language throughout this presentation. I acknowledge that trans men, non-binary, and other female-born people can and do carry pregnancies. And therefore, in this presentation, I use gender-neutral language whenever possible. Terms like pregnant people, pregnant individuals, and I do want to make sure that it is clear, though, that when I talk about depression in this presentation, that it's referring to the condition affecting the parent who carried the pregnancy. So regardless of whether it's gender neutral, it's not partner or what we would consider paternal depression traditionally. So the notation in the slides are using person, people, parent, or parents with an asterisk, just to indicate that that's the parent or the person who carried the pregnancy, just to avoid confusion. This is also with the caveat that the vast majority of the data that I'm referencing in this presentation only includes women in these studies, as far as we know. Very few studies to date on this topic include any measurement or analysis of gender. So that's definitely a direction that we need to go more into in the future. And I will acknowledge that depression of the parent who's not carrying the pregnancy is also very important, but it's a different entity. It has different etiology, often different symptoms, and definitely different challenges in terms of recognition and treatment. So perinatal depression is composed of depressive disorders or postnatal mood disorders. And they're partially characterized by occurrence either during pregnancy or the postpartum period. However, they do have a number of symptoms and signs that are unique to this disorder that separate them from depression in the general population. Typically, we have antenatal and prenatal depression. I refer to it as antenatal depression, or AD, throughout this presentation, and postpartum depression, which is more familiar and has a bit more awareness around it. It also includes baby blues, which is generally mentioned as sort of a something that's not a pathological condition. It affects between 60 and 80% of parents in the first 3 weeks postpartum, and usually resolves without treatment. You'll often see statements about it that it doesn't affect daily living or things like that. However, it does have very similar symptoms to depression, including frequent crying, anxiety about the baby, difficulty sleeping, changes in appetite, and that kind of thing. But typically the thing that really separates it from depression proper is that it will resolve without treatment, usually within a couple of weeks. Postpartum depression is the most common complication of pregnancy in Canada. So it's a very important condition that affects about 15% of pregnancies or of people who have been pregnant in the 12 months post-delivery. The vast majority of cases will materialize and develop usually within the first 6 to 8 weeks after delivery, but it can be diagnosed up to the 12-month mark post-delivery. It's a recognized psychiatric disorder in the diagnostic manual. It wasn't actually recognized as a proper disorder until 1994. And I mention that because this sort of late recognition of it compared with other depressive disorders is a bit of a reflection, I think, of the fact that it's a bit of a neglected condition. And there are some different reasons, societal and otherwise, that feed into that I'll touch on throughout the presentation here. One of the biggest points that I'd like to make is that it's important to remember that this is a very debilitating illness for the parent who's affected. We often hear about postpartum depression being important because it affects babies, which it does, and that is important, but we often lose the importance about the fact that it's a disease that's impacting the person who has it as well. And that's a bit of a mission of mine throughout my career is to make sure that that impact on the parent isn't lost. We do have a tendency sometimes to just sort of think, well, you know, pregnancy and that initial transition to parenthood can be hard. And so, you know, we expect that some difficulties come from that. And this is just something that you put up with after you've had a baby. But I think it's really, really critical that we continue to recognize that this is important because it's affecting a human being who's suffering through it, as well as having impacts on the offspring. So impacts on infants and children are prevalent. There are associated risks with both antenatal and postnatal depression. But I'll start sort of when I go through this first section, it's primarily dealing with postpartum depression, and I'll speak about antenatal depression directly a bit later. There are definitely important outcomes in the child associated with postpartum depression. Children are typically at increased risk of delayed speech, delayed cognitive development, and social and anger problems later in childhood. There is a marked difference in infants of parents with postnatal depression that affects self-regulation, emotional self-regulation. And this same disruption in emotional self-regulation is observed in parents who are affected by depression as well. Most importantly, I think to highlight in terms of the public health impact is that each case of postpartum depression is estimated to cost our health system in Canada around $150,000. So if we go by the current birth rate in Canada for 2020, we're talking about approximately $8.4 billion per year in Canada spent on treating depression and supporting people, both parents and offspring, through the negative sequelae that result from depression. So that's a huge chunk of change. And when we think of that, to those of us who spend a lot of time in this realm, it's really shocking that it's not more of a priority. And I think that's one of the biggest challenges that we have, is to try to get increased recognition and support through the health system for these conditions, because there really is quite a long-term market impact. So symptoms of postpartum depression are similar, as I said, to general depression. They include things like feeling sad or having a low mood, loss of interest or pleasure in activities that are typically you have interest in, changes in appetite, trouble sleeping or sleeping too much, loss of energy or increased fatigue, restlessness, feelings of being a bad mother or feelings of worthlessness or guilt, difficulty thinking, concentrating, or making decisions, thoughts of death, self-harm, harming the baby, or suicidal ideation or attempts, crying for no reason, and lack of interest in the baby, or not feeling bonded or connected with the baby. And traditionally, we would include feeling very anxious about the baby. So excessive worry that prevents sleep, excessive worry that prevents allowing support systems to come in and help. That also overlaps with postpartum anxiety, which I'm not really touching on here. But the screening tools and things that we use for depression often include a subunit that screens for anxiety. So it often gets folded in to the depressive disorder, but it is important to recognize that that can be a standalone condition that's serious as well. And I'm not covering that in detail today, but just a note to definitely recognize that that's possible. So historically, and even now, one of the biggest challenges with postpartum depression is identifying who has it and getting them the appropriate treatment. Excuse me. I'll go into more detail about this shortly, but in terms of identifying postpartum depression, many parents who are suffering with these symptoms are very hesitant to seek help. And that's sometimes because of the stigma around it, the fact that feeling guilty or like you're not a good parent or you're not interested or bonded with your infant can be a very difficult thing to speak about and to come forward with to a care provider or to other people. There's also a lack of recognition in the general population that this actually is a condition that you shouldn't be experiencing and that you should be able to get help with. A lot of people, I think, tend to think, as I mentioned before, that transition to parenthood is just really hard. And so, pregnancy has its challenges and that transition in the postpartum has its challenges, and it's just normal to be feeling this way. So one of our biggest challenges is really to increase awareness and make sure that people know that if they're having these symptoms for a week or more, that these could be things that they need help with to resolve. And when we think about trying to recognize who's got postpartum depression and who hasn't, you can see that from a measurement standpoint, a lot of these symptoms just sort of overlap with things that are going to happen when you have an infant in the house right after birth, especially when we consider sleep deprivation. So things that change automatically when you have an infant, changes in appetite, sleep changes, loss of energy or feeling fatigued. These things are very difficult to distinguish from what's typical of a healthy and normal postpartum experience in that transition versus when it's a pathology. So that's something traditionally that's been very difficult, or a challenge in this area, is to develop sensitive and specific screening tools that can identify postpartum depression, both in a clinical setting and for research. So for us to do research on this, we have to make sure that we're actually identifying people that truly have the condition if we're considering what risk factors have led to that or what treatments might work or might not work. One of the there have been many attempts over the years, therefore, to develop screening tools that really are able to do this well. Probably the most famous and the most widely used tool is the Edinburgh Postnatal Depression Scale, or the EPDS, which many of you are probably familiar with. The EPDS was developed specifically to detect postnatal depression and to separate it from both the typical postnatal experience of that transition to parenthood, as well as to identify it in distinction from other conditions that might be occurring. It's a 10-item scale. It's very quick and easy to administer. It takes less than 5 minutes to administer over the phone or in person. It's free, which is a very good thing for a tool in the realm of psychological measures. And one of the things that I really like about it is that there are literally dozens of translations available that have been validated. So all different languages, there are cultural adaptations of it as well. So it really is probably one of the best tools in our toolbox to screen for depression in clinical populations, as well as for health surveillance. And it's the go-to tool for me in epidemiologic research as well. It has good validity compared against a diagnostic interview, and it's reliable. So it can also be self-administered. So this is a good tool. I think a lot of clinics in Alberta are starting to use this during pregnancy, where they send the screening tool via an app to moms' phones or to parents' phones before appointments to do a little screen to make sure that things are not out of whack depression wise. So that's just a really good tool to know about. So there are other scales that are also validated for use in the postpartum, but the EPDS is the most common, and it really is, it's very useful because it's specifically developed for postnatal depression. So some of the challenges that we have with identifying postpartum depression in the population, first of all, finding the people who are at risk for it is a challenge. Having access to the population who are affected. Fortunately, that's one thing that's fairly easy in the postpartum, because parents do tend to have fairly frequent contact with the health system through pregnancy and after birth for postpartum checkup, and there are scheduled well baby visits and infant checkups. Unfortunately, not everybody does those things. Not everybody makes it to those appointments. So another aspect that is really being pushed for, and that some countries have made bigger strides in than we have, is screening. So broad population-based screening, where everyone after birth gets a phone call from public health and undergoes screening or receives a screening tool. As I said, some screening programs are going app-based for smartphones. But typically most of that is still happening via the telephone. In Canada, we don't have a federal screening guideline or mandate at the moment. And I'll talk a bit more about some of the reasons behind that in a moment. The awareness is really increasing about the importance of screening, but it's still typically left up to the province to figure out whether it's going to happen. So currently, BC, Manitoba, and Ontario have broad screening recommendations, but they're not implemented across the population as a standard of care. So there are definitely, there's definitely an awareness within public health that, you know, if a parent seems to be at risk or showing signs that this might be an issue, then some screening will take place. But we're not screening everybody in these provinces yet. Quebec has a recommendation to screen those who are at high risk, but that's still a bit touch and go, because high risk is difficult to define, and it's still left up to the individual care provider whether or not the parent should be screened. There definitely is a consensus in at least the research side of the community that broad population-based screening is a good thing and that it's worth the money. When we consider the financial impact of depression going untreated, it becomes apparent that putting money into screening programs to identify early and make sure people get adequate treatment is a good investment. The problem, though, is that treatment options are grossly lacking in Canada. So even in provinces like the Maritime provinces in Alberta, where we have broad screening mandates. So in Alberta and the Maritime provinces, every parent gets a phone call from public health and undergoes the screening using the EPDS tool before 6 weeks of post-birth. We don't then have very many treatment options. There are wait lists for clinic-based care in Alberta, for example, for postpartum depression are 6 to 9 months long. So that's really not ideal, obviously. Once we've identified that someone's struggling, we don't have resources to direct them to in terms of treatment. Psychology is available, but of course it's not a covered insured service, and it can be very costly. So it's out of reach for many, many people. Also, during pregnancy and breastfeeding, pharmaceutical options are not always a good idea. Not every parent wants to take medications when they're pregnant or breastfeeding. So that sometimes cuts that option off. And we do know from the evidence that it's really a combination of pharmaceuticals and psychiatric treatment or psychological treatment is really necessary to treat effectively. So some of the strides that we're making in postpartum depression is that the awareness of it is really increasing. We're seeing more about it in the popular media. Social media has been great for spreading the news of different supports and support groups that are out there. Parents are able to access support groups for postpartum depression in their areas, or even just virtually through social media. We're seeing an increase in screening, and I can't speak for the clinical situation in Manitoba because I'm not as familiar, but in Alberta, certainly we're seeing an increase in extra screening in postpartum clinics and during the well baby visits in Alberta. We also, because of this increasing awareness, are seeing more support seeking. So more people tend to come and seek out services, mental health supports, because they are aware that they're depressed. As I mentioned, the Maritimes and Alberta have routine screening, which is a great thing. So we've got at least one point of contact for every parent, hopefully, to screen. However, as I mentioned earlier, postpartum depression can develop later than 6 weeks. So although we do have that one early screening, we're still kind of dropping off the map to catch those later. Anything post 6 weeks is still difficult to capture. And we're sort of leaving it up to people who are affected to come forward and find treatment. There are increasing options for online and telehealth treatment, which is a great thing because there's still quite a bit of stigma attached to postpartum depression. And many people are deterred from seeking in-person services. So online or virtual telehealth treatment is a great option for postpartum depression. It also helps us to reach out to parents in remote places that don't necessarily have clinics nearby and don't, it's not feasible to pack up your infant and drive 2 hours to the nearest hospital every 2 weeks. COVID has actually boosted this awareness and this availability of virtual counseling, which is a really great thing. And I hope that that is a lasting side effect of all of our lockdowns and everything through this pandemic, is that more of those services will be available virtually on an ongoing basis. Unfortunately, though, the majority of cases of postpartum depression in Canada still go untreated or partially treated. So less than 50% of cases, and I will sort of mark this with the caveat that we don't have fantastic data about this, but from the evidence that's available, less than 50% of parents who are identified as having postpartum depression go on to complete a full course of treatment and recover from that. So that's a problem. And I think that until we really increase that prevalence of effective full-term treatment for people, those expenditures and that burden on the healthcare system and on the population, on people and families, is not going to go away. So then we also have antenatal depression, which is lesser known. It's not quite as well known or as familiar to people as postpartum depression, but it's also very common. It affects between 10 and 15% of pregnant people, which is an estimate. So our prevalence estimates for antenatal depression are not quite as strong as for postnatal depression. The 15% prevalence of postpartum depression is fairly stable globally, and that's fairly stable over the last couple of decades of measurement. We don't quite have the same level of evidence for antenatal depression, but we still typically in Canada, our large cohort studies tend to have approximately 10 to 15% prevalence, as well as the screening that we do in provinces that have the broad screening mandates that seems to also increase screening during pregnancy. And so where we have surveillance for that, that's where the prevalence falls, is around 10 to 15%. It's also very debilitating to parents. And it increases risks of preterm birth, small for gestational age, cognitive and developmental delay, and the same emotional and learning problems that we see with postpartum depression. Also very important to note is that 75% or so of people that have antenatal depression go on to have postpartum depression. So it becomes a lasting condition postnatally. And there are many factors that contribute to perinatal depression, but we don't really have a full understanding of the etiology. Traditionally, it was sort of chalked up to hormone changes and sleep differences and stress. And because there was this belief that it was just hormonal, that really was an underlying factor in the lack of recognition of it as a proper psychiatric condition or mental health condition worthy of diagnosis and treatment. A lot of things in pregnancy have been sort of passed off as hormonal changes. Unfortunately, perinatal depression, despite its seriousness, is still often neglected, and in some cases, even clinical practitioners are not recognizing that it's a serious disease that requires attention. Of course, there are sleep differences and stress involved in many cases. It's also important to note that inflammation and immune response is involved in perinatal depression. And it's fairly well known in research and sort of the etiology of general depression in the general population that inflammation is a factor, but that's less well studied in perinatal depression, and I'm going to touch on that again later in the presentation. Some of the risk factors that we have good evidence for are having a history of depression, having a history of abuse or other traumas or adverse childhood experiences, for example. Having poor satisfaction with social support or support from the partner can also increase risk of postpartum and antenatal depression. And then, of course, there are socioeconomic factors that can feed in, including having small social networks, being unable to communicate effectively in your first language, low income, and other factors that tend to be associated with health inequities in general can increase risk of postpartum depression and antenatal depression. So just a quick recap here. So overall, perinatal depression is a common and debilitating set of illnesses that are linked to negative outcomes both in the parent and in the child. They're extremely costly to the health system. And that figure that I presented is about 65% is estimated to be attributed to impacts on the child. So both in terms of the delivery or the birth admission in hospital, infants tend to need more intensive care, longer stays after birth, more readmissions and that kind of thing right in that immediate neonatal period, but also the long-term impacts of child behavior and learning difficulties are where those costs primarily sit. But it's still really important to recognize that 35% of that is still linked to that parental disease. And so again, I stress how important it is to recognize that that's an important condition for the parent. And there are difficulties as well with perinatal depression in terms of screening and treatment. So now I'm going to go a little bit into some of the research that I have going on that is sort of centered on developing and exploring treatment and prevention for these conditions in the perinatal period. And I just want to also say that this doesn't nearly touch on all of the great things that are going on in this area, but I will, I can't really speak as well to other people's research, so I'll give a brief overview of a couple of projects that I have going on. Oh, sorry, I've got a bit of a lag here happening. There we go. So I have a couple of ongoing research projects. One is a study of antenatal depression, and sort of involves looking at the inflammatory mechanisms involved. Um, it also looks at the child health impacts of antenatal depression. And one of the overall aims is to identify new treatment targets for antenatal depression. So I'm going to go into that one first and I'll give more detail. But then the second one that I'll come around to afterwards is a randomized controlled trial of a trained paraprofessional peer counselor intervention for the treatment of antenatal depression. And it was originally developed as a preventive for postpartum depression. Our first trial that's running right now is going to be looking, as I said, at treatment of antenatal depression, which should mitigate that 75% of people going on to develop postpartum depression as well. We're hoping to kind of cut that off before birth. And then eventually we will be doing a general preventive trial for postpartum depression. And one of the secondary outcomes of this study is to look at whether or not we can lower the risk of preterm birth in this group if we effectively are able to treat antenatal depression. So as I mentioned before, antenatal depression is linked with negative outcomes in the child, including cognitive, developmental delay, speech delay, emotional and social problems in children. So typically this connection has been attributed to a social mechanism or parenting. So the prevailing hypothesis is that parent is depressed, the parenting of that parent is therefore interrupted, the attachment doesn't happen properly, parent and infant emotional regulation ensues, and then the child is impacted by that. However, how does that explain these neonatal and pregnancy impacts that we see, like preterm birth, small for gestational age, and sort of the increased need for extra care in that immediate neonatal period? Because before birth, we don't have any parenting happen. So that points us in the direction that there must be some biological mechanism that's also at play that's affecting the fetus in utero. So as I mentioned before, it's well known that depression is an inflammatory condition. There is, in general, depression in the general population, we have fairly strong evidence that that depression is either triggered by or is causing systemic inflammation. So we also know that in perinatal depression that parental systemic inflammation could be present. The other thing that we know is that inflammation in pregnancy impacts fetal brain development quite severely. So both infectious and non-infectious inflammation have been linked to disruptions in structural and other brain development in the fetus, including conditions like cerebral palsy. And one of the key biomarkers of this inflammation are cytokines. So cytokines are cellular signaling molecules that are implicated in inflammatory response. So there's a set that we know about that are pro-inflammatory, and there's also anti-inflammatory cytokines. So these biomarkers are of interest to us when we're trying to figure out what that mechanism is going on between antenatal depression and some of the negative outcomes that we see with children. So, and I think I'll just step back a second to mention that we have to keep in mind that although 75% of parents that have antenatal depression continue to be depressed later, and so those behavioral parenting mechanisms may be at play, about a quarter or so tend to recover before delivery or at delivery. And those effects in the child ongoing are still seen. So that's really the primary reason that we're really interested in this inflammatory process. So it's well known, as I said, that depression in the general population is an inflammatory condition. And there are certain cytokines in that sort of inflammatory biomarkers in that group of chemicals called cytokines. And they're that are elevated in depressed people compared with those who aren't depressed in the general population. And we know that there's a direct relationship with some of these because some cytokines, for example, tumor necrosis factors, are sometimes administered in cancer treatment. And we see in those patients that are administered those inflammatory cytokines that there is a depressive response in the patient. So we actually have sort of a causal link in general depression for the importance of these biomarkers. However, very little is known about these biomarkers in antenatal depression. We know that it's inflammatory. It's not an exception to the general rule of inflammation being implicated. However, the inflammatory response in pregnancy is very different. It's quite complex. So during pregnancy, the fetus itself causes an inflammatory response, and the body then mutes that inflammatory response. So the muted inflammatory response is why we see sort of a lowered immune response to some pathogens like the flu, for example, in pregnancy. So that can be the fact that it's a muted response can complicate the study of which inflammatory biomarkers might be at play, because if the body is keeping these inflammatory biomarkers in very tight ranges, the differences between, let's say, the one biomarker that we see a mean difference of a certain degree in the general population between depressed and non-depressed people, that difference in pregnancy might be so small that it would require thousands and thousands of people to detect. A further complication is that the inflammatory response is so tightly regulated during pregnancy. And the main reason for that is that if the inflammation becomes too great, if we have a really strong immune reaction during pregnancy, that can actually cause the fetus to be rejected as a foreign body and cause miscarriage or stillbirth in some cases. So I believe, and there is evidence to support that the inflammatory response that we see in general population, where we might see one or two elevated biomarkers, is much more complex in pregnancy, and where we may see pro-inflammatory cytokines raised in one case, we may also see a drop in anti-inflammatory cytokines to sort of balance that out. And in pregnancy, whereas those differences may not be evident in the general population. So if we think about all of these different cytokines floating around, and I'm just using an example here of some of the ones that we know that are pro-inflammatory, and some of the ones that have been identified as anti-inflammatory cytokines that are in our system all the time that may be implicated in depression. We multiply that, let's say, by a sample of 700 pregnant people, we suddenly have thousands of data points, and it becomes very, very unruly. And our traditional analysis methods like regression or mean comparisons are really not powerful enough to allow us to analyze if and how they're all associated with antenatal depression. We also have issues with these chemicals or cytokine levels not being associated with our outcome in a linear fashion, or the data don't necessarily conform to the underlying assumptions of our traditional statistical analysis methods. So what we're trying to do in our study is to apply some machine learning analysis, and specifically classification and regression tree analysis, or CART, to try to sort through it all. So what CART does is it takes all the complex data and identifies which cytokines might be associated with the outcome, and then also at what level or what cut point in those levels it's important to for the association to become stronger. So it basically sorts the data so that you end up with probabilities of having the outcome based on the conditions that appear higher in the tree. So on the screen here, I've got the matrix on the left is sort of my visual representation of your thousands of data points, biomarkers. Let's say in our study, we have 42 biomarkers for 700 people. And then plus other risk factors that we know about, like socioeconomic status and other maternal or parental factors in terms of that we know could impact these things. And then on the right is an example of what a CART output looks like. So this is a classification tree where we see IL-7, which is one cytokine, is at the top. So when we move through this, we could say if a patient or if a participant in this data set has an IL-7 level of greater than 0.655 and an MDC level less than 390.7, they have roughly an 86% chance or 87% chance of having antenatal depression. So this is how we can sort of start to identify not only which biomarkers might be implicated, but at what levels they might become important. And so if we can identify these things, then we can potentially target these specific inflammatory pathways for treatment. And that's really the exciting thing about this. So I will mention that this classification and regression tree analysis is still underway for this study. And the one that I've put up here is actually for a different study that we did in the past with a smaller data set. So just don't take this at face value as these are the biomarkers that we need to be concerned about for depression. But what we hope to develop from this is sort of a set of indicators that could potentially be used for screening, or that we may be able to target with different anti-inflammatory treatments. For example, baby aspirin is a common one that we know is fairly safe during pregnancy and perhaps has some impact, but there are other potential treatment options as well if we know what the inflammatory process is going to be. A second step in this project is for us to look at whether or not these individual cytokines or the pattern of cytokines that we've discovered are associated independently with the changes or the difficulties that we see in children of parents that have had antenatal depression. So we also are looking at a 2-year follow-up point where we're looking at developmental outcomes. And I should mention that all of this data is coming from a larger parent cohort study called the All Our Families study, which is a big birth cohort of around 3,000 mother-infant pairs that were recruited in about 2009 to 2011. And they are still being followed up now. So we're working on the 12-year follow-up for that cohort. So we have a lot of information on the child outcomes in this population. So it should be exciting to see the results. The other ongoing research project that I wanted to touch on is a randomized controlled trial of a trained paraprofessional peer counselor model intervention. So as I said before, it's designed for the treatment of antenatal depression and the prevention of postpartum depression. And we're also hoping to see an impact for lowering the risk of preterm birth in our sample. So I'll just bring back a couple of things that are important for to sort of situate this study. So we know obviously that antenatal depression is associated with these negative outcomes in the offspring. It's also difficult to treat. So we have even less awareness and screening happening in pregnancy for antenatal depression than we do in the postpartum. So there's a very low rate of identification of antenatal depression. We also are limited, again, by the treatment options that are out there. We have very long wait lists and very few readily available, accessible services for people. And so that often means that people with antenatal depression don't get any treatment during their pregnancy, and the treatment may happen later down the road once the infant is born. And that's a very serious problem, because when we think about the direct effects of antenatal depression on fetal development, we have a very short window to intervene and to try to make a difference. There's also even higher stigma during pregnancy that people face. So that means that even those who are referred to a service, and there are services available, tend to have very low uptake of those services for various reasons, but stigma is one. So overall, we need accessible, sustainable, and desirable solutions for this, for treatment of antenatal depression. So we know also for antenatal depression and for postpartum depression that poor social support is a risk factor. And in fact, we've seen in several large cohort studies in Canada that looking at satisfaction with social support or spousal support during pregnancy is a protective factor against the development of postpartum depression, and this is specifically in Canadian cohort studies. We've also seen there are a number of trials that have happened in Canada for and other places where peer support interventions have shown some effectiveness in keeping postpartum depression from getting worse, or preventing EPDS scores from getting higher in the postpartum. So these peer support interventions do not provide psychological treatment. They are basically complementary to mental health services. And there are some big networks of peer support formally being developed. There's one in the UK. Australia also has a very strong one. And there are several less formal, smaller ones developing in the United States. In Canada, as I said, there have been trials, and there are some informal sort of grassroots groups that are coming up through social media that are just sort of self-run peer support for depression. But while there has been some promise shown with these peer support interventions, and the nice thing about them is that they're free and highly accessible, they're also not effective for actually treating existing depression, which is what we need. So we also know, just as a background thing, that cognitive behavioral therapy, or CBT, is shown to be effective as a treatment for postpartum depression. It improves symptoms in parents, and it also improves emotional regulation both in parents and in infants in clinical trials. So it's a promising therapy modality. It's also fairly easy to teach and learn how to administer if it's guided and supervised. And we also know, just as a background, is that psychology proper by a trained clinical psychologist is costly. And the uptake of in-person care is low in this group of antenatally depressed parents. So I was previously on a team that adapted and pilot tested a cognitive behavioral therapy, or CBT-based phone counseling intervention about, I'd say, 12 to 13 years ago. And in the pilot test, we had provisional psychologists who are clinical psychologists that are still completing their practical training in counseling, that we had administering this intervention. And the pilot feedback was that the parents loved it. The parents really, really found it effective and useful, but they wanted more contact with the counselor. They found having scheduled appointments with a psychologist was too rigid. Depression, one of the sort of side effects of that is that it can affect your ability to get organized, to get motivated, to make it to appointments on time and that kind of thing, and also to be the one who reaches out. So the intervention itself was successful. However, the method that we were administering it was not. So given the information that we had about peer support being effective, we thought, why not train peers to provide the CBT therapy in remote intervention? So that's how this trial was born. So at the moment in Calgary, in the Calgary region, we have a large birth cohort study starting called the P3 cohort, which is Prediction, Prevention, and Interventions for Preterm Birth cohort study. And my trial is nested within that study. So the P3 study is recruiting women in early pregnancy, parents in early pregnancy who are, and then any that score above 12 on the EPDS will be channeled toward us for our randomized trial. We are excluding people that are either in current psychotherapy or counseling for their depression, or that have begun a new regimen of pharmaceutical therapy during pregnancy. We're not excluding people that are in a current depressive episode who were on SSRIs, for example, long-term prior to pregnancy, because they're clearly not effective at the moment if their depression scores are that high. And then we're taking that group and they're being randomized either to the standard of care or standard of care plus our CBT, or in this case, sorry, I have BA as which stands for behavioral activation, which is very similar, the peer counseling intervention. And then we're going to be following up at 6 months postpartum. However, we have ongoing contact with the peer counselors and we're collecting data throughout that period as well. So the peer counselors are other parents from the community that we've recruited who have a history of postpartum depression, but have recovered and are free of depression at present. They have to have at least some post-secondary education, and that requirement is simply because we found that in our pilot studies, that group was better able to confidently and competently learn how to administer the CBT intervention. They are all vetted for suitability as peer counselors. So we sort of do a bit of an inquiry about emotional stability, whether they have the capacity in their lives to take on supporting a parent, and that they recognize the importance of evidence-based treatments. So they're not completely opposed to medications, for example, or, there aren't any sort of pseudoscience beliefs about, that crystals are going to cure these people, for example. And once they go through that vetting and suitability process, they are trained in a 2-hour session training program, which is followed by a competence and confidence testing period to make sure that they feel confident to administer it, and that based on the clinical psychologists on our team, that they are competent to administer this psychotherapy virtually for these people. They also have weekly clinical supervision from trained senior psychologists. And through that supervision, we also track the fidelity of the peer counselors to our intervention. And these moms, I should say, these parents are matched up one-to-one with our participants who have high depression scores in pregnancy. So the intervention itself is a 4-session work booklet with 4 remote counseling sessions that the peer counselor goes through with the person to complete or review the sessions if they've been done on their own. And it's intended to be completed prior to delivery, so over a 4-week period prior to delivery. But the peer counseling intervention also has the peer support component, which means that there is an unlimited amount of texting and phone contact that can happen between the peer counselor and the participant. And we leave that up to those two individuals to sort that out. It's generally very heavily text-based. People are quite comfortable texting each other, checking in, reaching out for help that way. And it expands into the pregnancy and infant care realm, and provides support or contact up to 3 weeks postpartum in a formal capacity. And we found in our pilot that many of these relationships go on to be permanent friendships afterwards. So, but we sort of stopped tracking at the 3-week point. And then again, our outcomes that we're measuring are the postnatal depression scores at 6 months, gestational age at delivery of the infant, and we're also going to be measuring some parenting self-efficacy to see if the intervention has any impact on the parenting pieces. So with that, these two studies that I've covered are sort of not complete. They're in process right now. So I'm happy to answer questions about those or anything else that I've presented. But just to give you an idea of some of the future directions for this work, we are going to be examining in the P3 cohort whether the peer counseling intervention alters the inflammatory profiles in women or parents who are participating in the cohort, because we are taking blood samples throughout pregnancy in a small subsample. And we'll be looking at whether anyone who's on baby aspirin as a prophylactic treatment for preeclampsia, which is still something that that a proportion of the population are going to be exposed to, we're going to be looking at whether or not they have different inflammatory profiles in antenatal depression versus those who are not taking baby aspirin. And then we're also going to be, as I said, moving this trial forward to look at treatment or prevention for postpartum depression. And we're also going to be looking at it for antenatal and postnatal anxiety. So thank you very much for sitting through that and listening to everything. I'd like to thank some of our grants and sponsors, as well as the cohort studies that are enabling these research projects to go forward. And I'll open it up for questions. I'm happy to answer any questions that anyone might have.